Health Professions Education in Sri Balaji Vidyapith University, Puducherry. And to chair the session, I'd like to invite Dr. Rakesh Segal, Dean AVMC, and Dr. G. Jayalakshmi, Dean SLIMS, Puducherry. I'd like to invite Dr. K.R. Sethuraman, sir, to deliver his opening plenary. Thank you, sir.
Dr. Jayalakshmi has not come, I think. Can I start? Madam? Well, very good morning to everybody. And today the first plenary lecture is by Professor K.R. Sethuraman. And first of all, I like to wish you a warm welcome to Puducherry and whosoever have come. Seeing the condition of Chennai at the moment with the typhoon and all, it is really great of all of you to come here, and I hope you enjoy the lectures as well as the really unpolluted environs of Puducherry. I can tell you this is even less polluted than Chandigarh from where I come. So this is one of the biggest plus points here. Anyway, so Professor Sethuraman, as Madam has already told, he is a guru of most of the people who have learnt medical education. He was the former Dean, Faculty of Medicine and Senior Professor of Medicine, AIMST, University, Malaysia. And he was for 25 years he has worked in the Faculty of Medicine, JIPMER, Puducherry. And from 2006 to 13 and 18 to 21, he was the Dean and Senior Professor of Medicine at AIMST, for 5 years, and Vice Chancellor SBV University, Puducherry, India. I think this was before, I think, Dr. Parija, I presume. Yes. So anyway, he has also been an international advisory panel for 4 editions of Davidson's Textbook of Medicine. He has authored 9 and edited 9 books and several video-based learning resources. His book, Trick or Treat, A Survival Guide to Healthcare, was a bestseller in its Tamil version. Well, the name is a bestseller. So he has guided 46 PG dissertations and 6 PhD scholars and 16 copyrights in innovative academic programs. He has published around 100 scientific papers in national and international journals, and he has also been short-term consultant to WHO for a few occasions during 6 years from 2000 to 2006. He has been a master trainer for World Bank Assisted Health System project in several Indian states. So this is a brief CV of Sethuraman, and you can see that he has been really a guru of medical education. And I would now request him for the talk today. Thank you very much. Thanks a lot for your kind introduction. Can I start with the first slide? Before that. No, the title. Yeah, the title is The Move Towards Authentic Assessment. I'm supposed to talk like a curtain raiser because there are other doyens waiting, Dr. Supe, TS, Professor TS and all that. So to continue, so this is mainly a curtain raiser, but people here often keep clicking. So what I thought is I'll put a QR code. You scan only once and you get the PowerPoint. The PDF is already put up, so you can download it in case you want to follow it on mobile phone or a tablet PC or something. Okay. So while you are scanning, I'll start with my profound thanks to Dr. Mahalakshmi. So as Professor Ananthakrishnan says, we throw a lot of seeds all around, but some seeds really go into mighty trees, like Dr. Supe here. He attended NTTC 31 years back. So a long association. And Mahalakshmi was also
JIPMER product and then personally groomed on medical education before she took formal training. So I'm thankful to these people for also remembering whatever we did instead of, you can throw the ladder and go off, but to remember the ladder is really a kind gesture. Thank you very much for that. So I dedicate this brief introductory curtain raiser to two people. One is Jerome Bruner. You know Bruner's theory of learning. So his quote is, "Knowing is a process and not a product." Very profound statement because it captures the essence of authentic assessment, actually competency-based learning. Knowing is just, especially in health professions, whatever we learn, cranial nerves, what do we learn them for? Ultimately, it's not a process of learning. The product is when a patient comes with cranial nerve problem, we are able to recognize that. That is the ultimate aim. So the product is when the person that we train sit in front of a patient and solve the problem. So that was a very profound statement. Simply said, knowing is a process, not a product. So that is the essence of today's talk. The second one is regarding assessment. Sometimes the more easily I have added there, sometimes the more easily measurable drives out the most important. That captures the essence of the challenges we face. Why we are not, Professor T.S. is going to elaborate on that, but this statement I think captures the spirit of what he is going to say. Why we often miss measuring the things that ought to be measured. I think Sanjeev is also going to talk on this theme later. So my agenda is very simple because others are going to fill up all the blanks, only to raise why competency-based curriculum, especially launched by this National Medical Council now, needs authentic assessment strategies in a big way, and consider 5 attributes. The curriculum has to be authentic. Only having assessment authentic is not enough. So see the 5 attributes of what is authentic curriculum and the factors that dictate how they are implemented. And the differences between traditional assessment that most of us are familiar with and authentic assessment, and the common myth that basic sciences cannot assess authentically. I just want to show 2 examples to open your mind that it is possible to do everywhere and how it benefits. Why? Why is a very difficult question which Maha has put, so I'll just confine to how it benefits the students and the society. Okay, so authenticity, there are several definitions. I'll just stick to 2 key statements. Focus on real life professional competencies is the essence of authenticity. So if it is a nursing curriculum, whatever they are supposed to do as nurses later, that should become the competencies, and training for that and assessing for that is the authenticity. So for this we need an authentic and aligned curriculum that promotes authentic teaching and learning and assessment of competencies relevant to that particular health professions. So therefore, in authentic assessment, students have to perform real-world tasks, both during learning stages and for assessment, to demonstrate meaningful application of what they have learned. So I've tried to avoid very high funda definitions because this is only a curtain raiser. Unauthentic is much easier to define. This professor, I had put Confucius, but Confucius is a great sage, so I deleted the name. I'll find some other name for this professor. I used to win medals in swimming, so he's going to teach swimming by an exhaustive lecture because he has got 200 PowerPoints slides on that. Then later he says, Miss Sheila is the best swimmer in the class because she has written the best essay on swimming. So this is very easy to define unauthentic. But curricular authenticity, if you is more serious business, not a joke, it has got 5 attributes. The first is, of course, relevance. Then second is scope. Third is coherence. And fourth is proximity. Fifth is feasibility. So I'll, this sound abstract because English is not our mother tongue, so I'll explain the factors, then it will become very clear what is meant by some words like proximity, coherence, those two especially. So, factors governing curricular authenticity, first we will take up relevance, needs analysis. So, what does Indian medical graduate need? What does Indian medical nurse need to function in India, function abroad? Because many of them go abroad also. So, the relevance is to pass, everybody wants NEET score so that they can get into the next stage. So, immediate concern is relevance for students is to get good outcomes in examination. But long term is what teachers are bothered about, the educators. Can they perform as an authentic physician, authentic surgeon, authentic nurse, authentic dentist, etc. So long-term career is also curriculum planners. And the scope, we have to consider breadth and depth. If you go very deep, then it can't go very broad. So in undergraduate, it has to be broad and not deep. Except certain common diseases, probably they have to learn in depth. So then other one about scope is specific competency. Do we go for specific competency or broad generic principles that can be applied to different situations? Both are necessary. So specific competencies as well as broad principles that they can apply learning later because medicine keeps changing so frequently. Then we go on to this coherence. Coherence means when the student comes and sits in the class and after +2 he comes and joins first year MBBS, anatomy teachers talk Latin and Greek, then physiologists come and say something, biochemists say something, in between ADCOM, it's like a commercial break, that also happens. So whether it has coherent, do we ever ask students, do you feel incoherent or coherent? Why do people take drugs? Why do they jump from library top? So because of incoherence. So within the subject we should have coherence. More importantly, across the subject. So very simple, when anatomy is teaching some subject, if the same topic is covered in physiology, biochemistry, they will have some coherence. So it is by content sequencing. It is a tough work, but if everybody cooperates, it can be done. Our Malaysian AIMS curriculum is like that. We do molecular and cellular basis of medicine. It's not anatomy, physiology, biochemistry. MCB on paper 1, paper 2, paper 3. So everything comes together. So it is possible. It's a British curriculum available everywhere. And proximity, external closeness to practice, later life. That IMG is supposed to do so many things. Are we training? And second is internal appropriateness to learner ability. He has come from +2. Straight away we can't say early clinical exposure, go and see a case of stroke or mitral stenosis and all that. It won't make sense. So internal appropriateness to a learner ability in first year, second year, third year, it has to be progressive, UG, PG. And finally, feasibility based on 5 M's. Manpower, that is health, human resource for teaching, educators, the funding, curriculum funding, learning resource material, the curriculum time, that is minutes, and finally, 5th one is motivation. Are we motivated to teach? Because whether you teach well or not, the same salary is given, everything is same. So unless we are motivated to offer authentic training and authentic curriculum, it won't work. So just for remembrance, I put as man, money, material, minutes, and motivation. Okay? And as I said earlier, the whole thing has to be aligned. It's not just the authentic assessment alone. So first of all, what we want our students to learn, the intended curriculum, then it goes to the taught curriculum. Do we teach everything that we intended them to learn? Then It was a challenge during COVID, but not nowadays. Experience curriculum, that of course differs from students to student. And assessed curriculum, are we assessing competencies that we intended them to learn in our curriculum? Then finally, the results, the final outcomes achieved by our cohort of students. And it is an ideal world. Number 5 and number 1 will be totally aligned, but in reality there is always a gap, curricular gap. What is the gap between what we intended and what we achieved after 4.5 plus 1 year? So that is the challenge for educational planners if you want to really do competency-based education and authentic assessment. And Indian medical graduate is a very laudable utopian dream that we will have products coming out as effective clinicians and with leadership skills, communication, soft skills, professional abilities, competencies, and being a lifelong learner. So for introspection, how many of these competencies are we assessing authentically? So not only training, but because the power of assessment that drives learning, individual and contemporary society is not so much described by tests as constructed by them. So if you have an assessment, a formative assessment for 4.5 plus 1 year, I think it is feasible to achieve and construct IMGs out of our students. So that means we have to shift from traditional mindset to authentic mindset. Selecting a response, especially MCQ, they have to just think which is right and then circle, to performing a task that is authentic. It may be a cognitive task, communication task, or a psychomotor task. Contrived test items to real life tasks being assessed. Recall and recognition based tests to construction and application based higher order tests. Then teacher structured items to student structured item. That means the student has a say in saying whether it is too difficult, too easy, etc. in the formative stage. So what it means is students have a say during formative phase, not, of course not in the final test items, which is a confidential exam. Indirect evidence to direct evidence of learning, because that is authentic. And how do we do that? So as in the key principle says, we apply to real life situations, provide hands-on activities, multiple skills tested in a task as a competency, then demonstration of ability to apply knowledge, not mere knowledge, that's what he said. It's a process and not a product. Test the product, problem solving ability. Then ongoing throughout a unit of study as a comprehensive, continuous formative assessment, and it should reflect growth in every student of the skill and competency from year 1 to end of internship. And of course, Miller's pyramid helps us plan to move from just mere knowledge testing to show how and does. So that is possible. And many others. Yesterday itself, Miller's pyramid came in all the halls. So then authentic assessment should also be inclusive. It's very easy to just test the top benchers, gold medalists and the prize exam and say, we do authentic tests. But everybody, including the backbenchers, have to be included, and that we allow everybody to demonstrate their core competencies. And it is through assessment for and assessment as learning. And every student is given a graph. Dr. Maha used to do as deputy dean in our university earlier, and now she is doing in Arubade Vidu. I suppose it's still being continued, Maha. Everybody gets this is called a spider graph or a radar graph, where the achievement of the expected achievement is the outer one, average achievement is the white line, and the individual, the particular candidate, and is a black line. So like that everyone is given what is optimum and what is achieved by the whole group and where are you standing. Okay. So for authentic assessment, this assessment for, assessment as and assessment of learning, I prefer this Earl 2003 article. Others have mixed up the assessment for learning and assessment as learning. Unfortunately, they have not separated out. Many use it as similar synonyms, but it is not. Earl has clarified. This is diagnostic testing. Before they start, when plus 2 comes to first MBBS, the diagnostic testing done is assessment for learning. Assessment as is formative during, and when they exit it is summative, pass-fail. That is assessment of learning. There is no controversy. So identifying the level of knowledge and skill prior to instruction. So that is for. As is repeated continuous assessment. Then assessment for enables the teachers to adapt to learners' needs, individualized. Then the backbenchers who score very low in assessment for, we can give what is called accelerated learning. I'm not going to talk about that because that will take 1 hour. You can just Google accelerated learning model. There are plenty, including health professions education. So that with that they can catch up. There is no need for them to spend extra 6 months, but within the curricular time, using accelerated learning model, it is possible to get them on board. So it enables us to focus on required instruction, a very efficient way of running the curriculum. Assessment for learning is done. Assessment as learning and assessment of learning, we all know, so I'm not going to spend time. So we start with basic sciences, and the myth is clinicians very easy. They often come and tell me, you are professor of medicine, you can do authentic tests, say, go and examine a case. What can we do in anatomy, biochemistry? No, I'm not here. In Malaysia, I used to be challenged because we do competency-based curriculum. So then all this is being done there. In skill lab, anatomy lectures take, and then they teach on mannequins, how to identify various tissue planes and give intradermal injection, subcutaneous, intramuscular, Z technique for deep muscular injection of iron and all that in clinical anatomy. I'm just giving one example. Like that, there is a big list. They'll be happy to share with you if you want to know. And similarly, in bilirubin metabolism, when it is taught in biochemistry, how to explain physiological jaundice of newborn. Every newborn becomes yellow after a few days. And parents are anxious, especially first baby. So instead of waiting for pediatrician to teach, this boring bilirubin biochemistry can't be enlivened by just 3 minutes nested session where a pediatrician come and explain, and it can be done as OSCE testing. Explain physiological jaundice to the parents in native, in local vernacular, in Hindi or Tamil or whatever language, they should be able to explain. So it can be done in year 1, and it will make a sense. And when they learn biochemistry, bilirubin, they will not say it is boring and throw off or try to copy. They will learn it with relevance, with it is going to be useful later in my life. Okay, so this is the last slide, I think. Benefits to students, to say why we should adopt CBME and authenticity. Because as 8 students preparing for complexities of professional life and motivates them deeply. So they know why they are learning bilirubin metabolism. They know why they are learning various tissues so that later when they give injection, they can be very specific. And so therefore, it makes a lot of meaning, and it more constructive and productive of learning of outcomes, and students know that they are prepared for lifelong learning and lifelong practice of whatever professional skills they have to show. This is the last one, because some doyens are there like TS and AS and all that, so I can't go with the minimum slide. So one special slide from me. 7-level outcomes. So we all know Kirkpatrick's 4-level outcome. So this is a new one which I adapted, I converted to healthcare professions. I put it up on the net already. This is copied from that. So participation, students engage fully in the course. If it is authentic, they'll get fully engaged. Satisfaction, they get satisfied. They know that they have got all the qualities of Indian medical graduate when they go out. If the spider graph as a proof, then they learn declarative knowledge, that is know of Miller's pyramid, the bottom, then procedural knowledge, know-how of Miller, then learning competence, show-how of Miller, learning performance, do of Miller, and level 6 is, does it improve patient outcomes when they are interns? Medical superintendent can easily get the data, monthly audit and all that, safe and effective patient care. Then this is from society. Is there a improved healthcare statistics and outcome in the community? So that is our ultimate aim. We are teaching not just to make doctors, but ultimately it is to help the society. So we have to broaden our vision for competency-based education to try and achieve the 7th level of outcomes. So therefore, authentic assessment is holistic and occurs in real-world context, and it is meaningful, and criteria is known a priori. That means the students know, the teachers know, everybody knows. And it can be shown, especially assessment of learning, and the spider graph becomes, can be showcased publicly, and effective delivery of competency-based education in health professions aims to improve societal health ultimately. So these are some references, and thank you very much. Thanks, Maha.
Thank you, sir, for a very good and concise talk on the subject of assessment. Well, I just want to make a small comment that we are, as you could say, this is, for me, is also a learning exercise, because I am also from the old school. We had the system where the assessment was totally, not really different. The assessment is more or less the same, but we have refined it. And the refining is very good now, and you have sort of across all colleges you can have the same type of assessment. So there is, that is also a very good thing. There it was not really structured like what it was now. But anyway, only thing which worries me is the student involvement, and sort of letting the students do some sort of a thing in that, because these days students, I don't know how good they will do, and I think a bit of discipline has to also to be maintained. Less it should be, but the teacher, more should be teacher and student centric also. So that is my comment. And madam,
can I answer that, your comment?
yes,
I agree. Even in Malaysia it's like that. I took ECG class, I've been taking from 1974, I think, 75. So earlier they used to listen, but this current batches, they have everything on Google. They don't look at you at all. 2006 to 13, they were listening to me. When I went back in 18, by then Apple, everything has come. 4G, nobody looks at you. So I've changed. I have to change myself. Now I do flipped class. I give this PowerPoint through WhatsApp, so they all read up and come. And I give them ECGs. You are posted in emergency room, and this is the case, this is the ECG, crack. Give them 20 minutes. Fully engaged. They use mobile phone and all that, but it is for learning purpose. So I take 2.5 hours, they are fully engaged. So we have to change. I've totally changed from my earlier classes to the current class. So, yeah, that's, I agree with you. So we have to reform ourselves so that our students benefit, because they are a different generation.
we have so much information now available on the net and all, because at our time it was all hard copies and you had to have a book and read. So I think what needed, we have to change, which is a difficult thing in our age, because things are so sort of, we are tuned towards something, but anyway, since change has to be there from our side also.
True.
Good morning, everyone. First of all, I apologize. I was late by 3 minutes because I held up in congestion. And Professor Sethuraman sir, I know he is a brilliant teacher. My association with him from Madras Medical College as associate professor during 1998 in NTTC program. Sir was there and we had a wonderful time spending there. Then only I learnt what is medical education and these technologies. From that time, I have been wondering whether I could meet him again, and I thank Mahalakshmi Madam for giving me this opportunity to meet my senior professor from Jimmer. Thank you, sir. And regarding authentic assessment, yes, as faculties, we are also struggling because this new change of innovation has been exhibited by Madras National Medical Mission from 2019. So everything they want the curriculum change. But as such, faculties have not been given enough training. Yesterday discussion also was based on that. So first, the National Medical Mission also, NMC, has also improved. It has to improve the faculty development program. Now they have made mandatory this medical education certificates, everything for promotion and all. But still, the faculty development program should be one of the regular course itself. Then if it is there, then it can be done. That's what I feel, sir. And not only the faculties alone should be concentrated, it should be of all the healthcare providers must be given the health education. It is a teamwork based. One is doing and other is not doing. It is very difficult to establish. Even if I want to project whatever the high-fee PowerPoint, I need one attender who is not trained. So he will not be interested. So everybody should be involved and it should be trained as a teamwork. That's what I feel. And this sort of, this reluctance attitude among students about sitting and listening lectures and all, that we have also witnessed. So to change this, we have to adopt the modern innovative medical education and technologies like flipped classroom and what sir says, IoT technique and other clip arts technique, gemation and so many video games with the medical education, that everybody should be trained. Then only they can also implement. And the student also, I feel, from year one, they should have some medical education class. If it is conducted, then they all will be tuned. They will become one of them. And the ultimate aim of our nation is final health care outcome, patient safety, personal safety, community safety, and exhibition of all these criteria. For that, we all have to work as a team. That's what I feel, sir.
Thank you, sir. I think we can stop here because we are running short of time, getting a bit late for the next part of the program. Once again, thank you very much, sir, for such a concise and good lecture.
Thank you, sir, for an excellent and informative session on why authentic assessment. Now, I'd like to invite I request the resource person, Professor K.R. Sethuraman, sir, to be on the stage. We'd like to honor you. Now, I'd like to invite our chairpersons, Dr. Rakesh Sehgal, Dean AVMC, and Dr. G. Jayalakshmi, Dean SLIMS Puducherry, to honor our resource person, Dr. K.R. Sethuraman, sir, with a memento. Thank you, sir, ma'am. Now I would like to invite Dr. Dinkar Pai to present the memento to the chairpersons, Dr. Rakesh Sehgal and Dr. G. Jayalakshmi.